Welcome back to the deep dive. Today, we are taking on a really huge chapter in medical surgical nursing, one that impacts virtually every single patient care setting.
It really does.
We're talking about the comprehensive management of gastric and duodenal disorders.
Yeah, we're going to be slicing through the high-stakes world of gastritis, peptic ulcers, and then, the really unforgiving diagnosis of gastric cancer.
This deep dive feels absolutely foundational for any clinician.
It is. I mean, the sheer prevalence of these conditions, especially things like peptic ulcer disease and chronic gastritis,
Yeah.
means that if you're taking care of adults,
Right.
particularly those over 60, you will encounter these cases, no question.
So our mission today is to give you that clinical shortcut.
Exactly. Understanding the etiology, the deep pathophysiology, and, the absolutely critical nursing care that goes along with these GI disorders straight from the core textbook material.
That's our promise, a shortcut to being well-informed. Now, before we explore the diseases themselves, I think we need to establish the clinical language we'll be using.
Yes. Good idea.
Mastering these terms is really that first step toward efficient patient communication and, of course, assessment.
Agreed. Let's start with acidity. We talk a lot about stomach acid, hydrochloric acid, or HCl. When the stomach completely fails to secrete HCl, that condition is called achlorhydria.
Achlorhydria. And that lack of acid has some profound implications we'll definitely touch on later.
It does. Then you have the more common symptoms of discomfort.
Right, like dyspepsia. That's the general term for indigestion, isn't it? That sort of non-specific upper abdominal discomfort you get with eating.
Exactly. It's that vague stomach ache that patients so often report. But more specific is pyrosis.
Pyrosis, that's the classic burning sensation that moves upward, what everyone really just knows is heartburn.
That's the one. Now, when we talk about these disorders, we have to immediately think about bleeding. It's the most common complication.
So we have two key terms here, and they tell us where the blood is coming from and how it's been processed.
All right. First is hematemesis. That's the vomiting of blood. It can be obvious bright red blood, or if it's been partially digested by stomach acid, it'll look like dark coffee grounds.
And the other sign is melena.
Melena? This refers to those tarry, sticky black stools. And that dark tarry appearance is from occult blood that has traveled all the way through the digestive tract and been chemically altered by bacteria.
Recognizing melena is a huge, non-invasive way to spot an upper GI bleed.
It is. And finally, a term that comes up mostly after surgery, dumping syndrome.
And this isn't just a bit of indigestion.
Oh, not at all. It's a profound systemic physiological response. It happens when gastric contents empty way too rapidly into the small intestine, and that leads to symptoms like weakness, nausea, sweating, even syncope.
We are definitely going to spend a lot of time on how nurses manage that.
For sure. So with that vocabulary established, let's dive into our first major topic, which is really the umbrella where a lot of these other issues begin. Gastritis.
Gastritis. So defined simply as the inflammation of the gastric or stomach mucosa, but it's anything but simple in its causes or consequences.
Not at all. It's an incredibly common GI problem, and as you mentioned, its incidence is increasing sharply in the adult population, especially anyone over the age of 60.
And we classify it into two main forms, right? Acute and chronic.
That's right. Acute gastritis is transient, so typically lasts only hours to maybe a few days. Chronic gastritis, well, that's a dangerous one. It results from repeated episodes or continuous irritation, and it leads to long-term tissue changes.
So let's focus on the causes, the etiology. Acute gastritis can be erosive or non-erosive. When we're talking about erosive acute gastritis, what are the most frequent offenders nurses need to know?
The list is pretty long, but the major culprits are local irritants we see every day, aspirin and other NSAIDs like ibuprofen, corticosteroids, and of course, significant alcohol consumption.
Even radiation therapy.
Yeah, radiation to the abdominal area can be a direct cause. These agents physically or chemically damage that protective layer.
And if it's non-erosive acute gastritis, the prime suspect is almost always that persistent bug, Helicobacter pylori, or H. pylori.
That's right. H. pylori is a gram-negative bacterium that is, colonized an estimated 50% of the entire global population. It's incredible. And while it often causes a long-term chronic infection, it can certainly be the initial trigger for an acute episode.
Now, in the acute setting, we have to recognize the really severe forms. If a patient ingests a strong acid or an alkali, what are the immediate catastrophic risks?
That is a true medical emergency. The ingestion of a caustic agent can cause the gastric mucosa to become gangrenous, meaning the tissue literally dies, or it can lead to perforation, which is life-threatening.
And if the patient survives?
The scarring from that intense damage can later cause pyloric stenosis, where the opening of the stomach narrows, and that leads to obstruction.
We also have that specific subset you find in critical care settings. Stress-related gastritis, which often leads to stress ulcers.
Yeah, and this is different from the other forms. It happens when a patient is under severe physiological duress. Major trauma, extensive burns, severe infection, or just a lack of blood flow or perfusion to the stomach lining. It's an acute process.
So it's related to the stress response itself, not necessarily diet or H. pylori.
Exactly. Now, moving to chronic gastritis, H. pylori once again takes center stage.
And why is that chronic infection such a major concern?
Because it's an insidious, a slow burn disease process. That long-term inflammation from H. pylori isn't just causing indigestion, it's strongly implicated in developing peptic ulcers, and critically, it's a known risk factor for gastric malignancies.
Like gastric adenocarcinoma.
Adenocarcinoma, and also a rare form of lymphoma called MALT, that's mucosa-associated lymphoid tissue lymphoma.
Are there any non-infectious causes of chronic gastritis we should know about?
Yes, chemical gastropathy is a notable one. You often see it in two scenarios. Either long-term, heavy reliance on NSAIDs, or as a consequence of previous gastric surgery, like a Billroth procedure.
So the reflux of bile and duodenal contents persistently irritates the stomach tissue.
Exactly. We also see autoimmune associations, where chronic gastritis goes hand in hand with conditions like Hashimoto thyroiditis, Addison disease, and Graves' disease.
So let's pull the camera back a bit and look at the underlying process here, the pathophysiology. What's the fundamental mechanism that connects all of these causes?
The core mechanism is the disruption of the mucosal barrier. You have to think of the stomach lining as this highly effective self-defense system. It's designed to protect the tissue from the powerful digestive acids and enzymes it produces.
And when that barrier is damaged?
When it's damaged by acid, pepsin, NSAIDs, inhibiting protective factors, or H. pylori attacking the cells, it allows those corrosive agents to penetrate the mucosa, and that is what triggers the inflammation.
So what does that look like when the inflammation is acute?
In the acute phase, the inflammation is transient, but it's very dramatic. The mucosa becomes edematous, swollen with fluid, and hyperemic.
Hyperemic meaning congested, red, and swollen with blood.
Exactly. And if this leads to superficial ulceration, that's when we see bleeding, and it can be a severe hemorrhage.
And in the chronic phase, the damage is more systemic.
That's where it gets really concerning. Persistent insults lead to chronic changes, and eventually atrophy, or a thinning, of the gastric tissue. This tissue atrophy is the key to understanding the most serious, long-term systemic manifestation of chronic gastritis.
Which brings us directly to the clinical manifestations. Let's compare the rapid onset of acute symptoms versus those more subtle signs of chronic inflammation.
Acute gastritis hits fast. You'll see a rapid onset of epigastric pain or discomfort, dyspepsia, anorexia, maybe hiccups, and the classic nausea and vomiting.
And if it's an erosive type?
Then the bleeding signs hemiadmesis or melena will be obvious.
Chronic gastritis symptoms, though, they often don't scream emergency. They're much more vague.
Very vague. Persistent fatigue, pyrosis or heartburn that just seems to happen all the time after eating, belching, a sour taste in the mouth, halitosis, and feeling full almost immediately after starting a meal, what we call early satiety.
Right. The patient might just say they can't tolerate fatty or spicy foods anymore.
Exactly. But the clinical nugget we highlighted earlier, stemming from that mucosal atrophy, is the most crucial systemic consequence.
Okay.
The atrophy diminishes the production of intrinsic factor by the parietal cells. And since intrinsic factor is absolutely essential for vitamin B12 absorption in the small intestine, a lack of it leads directly to pernicious anemia.
And that is a non-negotiable fact in patient education.
Absolutely.
So how do we confirm this diagnosis?
Well, the definitive method is always going to be an endoscopy with a biopsy. We need to look directly at the tissue and analyze it histologically.
Then labs.
Labs are also essential. A complete blood count, or CBC, helps us look for signs of blood loss anemia, or, if it's chronic, that specific macrocytic anemia that's associated with pernicious anemia.
In terms of medical management, let's start with acute gastritis. You mentioned the mucosa is generally self-repairing.
That's right. Recovery is typically pretty fast, maybe a day, though the appetite may lag a bit. So the initial management is entirely supportive. You remove the irritant.
So refraining from alcohol and food until the worst of the symptoms pass.
Right, and then progressing to a bland, non-irritating diet. If the symptoms are severe or persistent, We manage fluid and electrolyte balance aggressively with IV fluids.
And if bleeding is the issue?
If bleeding is evident, we jump right into the protocols for upper GI hemorrhage management. That means an NG tube for monitoring and decompression, antacids, H2 blockers like famotidine or the powerhouse acid suppressors, the proton pump inhibitors, or PPIs like omeprazole.
And in those rare, extreme cases involving caustic agents or severe obstruction?
Then emergency surgery, a resection or bypass may be the only option.
For chronic gastritis, the focus really shifts to long-term modification.
Yes, this is a lifestyle management issue, really.
Huh?
Patients have to rigorously modify their diet, reduce stress, get adequate rest, and strictly eliminate alcohol and NSAIDs.
And medically.
Medically, we rely on the same acid-suppressing drugs. And critically, if H. pylori is confirmed, we have to initiate eradication therapy, which is typically a combination of a PPI and 2 to 3 antibiotics, sometimes including bismuth salts.
This brings us to the foundation of care. Nursing management of gastritis. What are the core priorities here?
First, reducing anxiety. Especially if the cause was traumatic or involved a caustic ingestion, the patient is going to be terrified. So the nurse provides supportive therapy, uses a calm, reassuring approach, and thoroughly prepares the patient for all diagnostics or any potential surgical procedures.
Then, promoting optimal nutrition and fluid status.
For acute symptoms, the patient must be NPO. You have to let the stomach rest and heal. We diligently monitor intake and output, tracking electrolytes if they're on IV fluids.
And reintroducing food.
It has to be systematic. You start with ice chips, then move to clear liquids, and then progress to solid food as quickly as tolerated to minimize dependence on IV therapy.
What are the absolute no-goes in terms of substances?
Caffeinated beverages, and that includes decaf coffee because they stimulate acid and pepsin secretion, so they have to be cut. Alcohol is a direct mucosal irritant, and smoking is just terrible for this.
Why is that?
Nicotine levels in gastric acid are extremely high, which increases acid secretion and damages the mucosal barrier. Counseling and cessation referrals are paramount for long-term recovery.
And for fluid balance, what are the specific metrics we're tracking?
We're aiming for a minimum fluid intake of 1.5 liters per day, and we monitor urine output closely. Ideally, we want to keep it above 1 ll per kilogram per hour, which is the benchmark for adequate hydration. And we need electrolyte checks every 24 hours to spot any early signs of hypokalemia or dehydration.
And of course, we must always be vigilant for bleeding.
That's the hemorrhagic alert. The nurse is the first line of defense here. We check for hematemesis, signs of early shock like a subtle tachycardia or a drop in blood pressure.
And you check every stool.
Every single stool needs to be checked for occult blood, even if the patient reports normal coloration. Any sign of acute bleeding demands immediate notification of the provider.
The teaching component for home care is immense, especially for those with chronic gastritis.
It is. The education reinforces stress management, adhering to dietary modifications, avoiding irritants, and strict adherence to any medication regimen, particularly the antibiotics for H. pylori eradication.
But if the patient developed pernicious anemia due to that atrophy?
That key takeaway is a matter of survival. They require lifelong vitamin B12 injections. They need thorough teaching on how to administer those injections, either by themselves or through home health support.
We transition now from transient inflammation to peptic ulcer disease, or PUD. And this is far more serious. It's an excavation, a hollowed-out area in the mucosa.
Exactly. It can occur anywhere from the stomach to the duodenum. And PUD is a highly prevalent condition. While the incidence is stabilizing in younger populations, it's alarmingly increasing in older adults.
Particularly women, right?
Yep.
Often linked to rising NSAID use.
Exactly. It affects millions annually. And while chronic gastric ulcers are typically found near the pylorus on the lesser curvature of the stomach, duodenal ulcers are far more common overall.
Historically, we used to focus on type A personalities and stress, but modern research confirms two dominant, intertwined causes.
Right. We know now that the two major risk factors are the same ones we discussed for gastritis. H. pylori infection, which is transmitted through contaminated food, water, or close contact. And the other is the chronic use of NSAIDs, including aspirin.
So how do those two interact to create a serious ulceration as opposed to just inflammation?
It all comes back to that protective barrier. NSAIDs inhibit prostaglandin synthesis, and prostaglandins are essential local mediators that promote mucosal blood flow, bicarbonate secretion, and mucus production. They're basically the stomach's natural shield.
So when NSAIDs disrupt that,
When NSAIDs disrupt prostaglandin production, the protective barrier is severely weakened, and that makes the mucosa far more susceptible to attack by H. pylori or even just normal levels of acid and pepsin.
are there any specific population groups at higher risk?
Yes, people with blood type O are shown to have a higher susceptibility to H. pylori infection and then subsequent ulcer formation. Also, chronic diseases like COPD, kidney disease, and cirrhosis all increase the risk.
Probably due to the chronic stress on the body and potential ischemia.
I would think so. And we also have to address the rare but dramatic cause of hyperacidity, Zollinger-Ellison syndrome, or ZES.
ZES is a crucial exception to the standard PUD picture.
It is. It's caused by tumors called gastrinomas, usually found in the pancreas or duodenum, and these tumors secrete massive, unregulated amounts of the hormone gastrin.
So that gastrin overload leads to extreme gastric hyperacidity.
Exactly, which causes severe resistant PUD. It's very aggressive.
I can imagine.
Yeah, and about a quarter of ZES cases are associated with an inherited genetic condition called multiple endocrine neoplasia, type 1, or MNN1. Sometimes the first clue a patient has ZES may be signs of hypercalcemia, which can predate the full MNN1 diagnosis by years.
Wow. Okay, so let's focus on the classic pathophysiology, the acid pepsin attack.
PUD is fundamentally a defect in the gastroduodenal mucosa's ability to withstand the digestive action of its own components, HCl and pepsin. So the ulcer develops because either the acid concentration is too high, or the mucosal resistance is too low, or, a devastating combination of both.
And there's a key difference based on location.
Absolutely. Patients with duodenal ulcers typically secrete more acid than normal, which overwhelms the resistance factors.
But patients with gastric ulcers,
Conversely, they often secrete normal or even decreased levels of acid. In gastric ulcers, the issue is almost entirely a profound impairment of the mucosal barrier itself. So even standard acid levels can cause erosion.
before we get to the standard PUD symptoms, let's quickly differentiate the acute stress ulcers again, curling and Cushing.
Right. So stress ulcers are truly acute mucosal ulcerations that follow profound physiological stress burns, sepsis, shock. They're ischemic in nature. That intense stress causes decreased blood flow to the gastric lining.
And curling ulcers are specifically associated with massive burn injuries.
That's the one. And Cushing ulcers are associated with traumatic brain injury, stroke, or intracranial surgery. The theory is that the intense intracranial pressure overstimulates the vagal nerve, which leads to massive acid secretion. Cushing ulcers are known for being very deep and carrying a particularly high risk of perforation.
Okay, back to the classic clinical manifestations of PUD. What is the signature sign we tell the learner to watch for?
The signature is that cyclic, dull, gnawing pain or a burning sensation, usually localized in the mid-epigastrium or sometimes radiating to the back. But the absolute clinical cornerstone for differentiation is the timing of that pain relative to meals.
Okay, unpack that crucial distinction for us.
For gastric ulcers, the pain most commonly occurs immediately after eating. Food intake triggers gastric emptying and acid release, and that causes immediate distress.
But in stark contrast, duodenal ulcer pain.
Typically occurs 2 to 3 hours after meals. The pain frequently wakes the patient up at night. Up to 80% of duodenal ulcer patients report nocturnal pain.
And critically, this duodenal pain is often relieved temporarily by eating food or taking an antacid.
Because that buffers the acid.
Exactly.
That difference in timing is an essential piece of diagnostic information, especially in the initial triage phase.
Other symptoms can include pyrosis, sour eructation, that burping when the stomach is empty.
Right, and sometimes vomiting, though that suggests the ulcer might be causing some obstruction.
Hmm.
We also look for signs of bleeding, melena or hematemesis. But remember the warning. Up to 20% of PUD patients who present with bleeding have reported no abdominal pain beforehand.
Silent ulcers. And then the catastrophic event, perforation.
This demands immediate attention. The moment of perforation is signaled by sudden, severe, sharp upper abdominal pain. The pain may radiate to the shoulder because the leaking contents irritate the phrenic nerve.
What are the key physical findings the nurse should look for?
Extreme abdominal tenderness and rigidity. The classic description is a board-like abdomen. It's firm, rigid, and intensely painful to the touch. This patient is quickly spiraling into shock, showing hypotension and tachycardia. It's an abdominal emergency that needs immediate surgery.
So if we suspect PUD based on the history and symptoms, What's the definitive way to confirm the diagnosis and plan treatment?
The preferred method is the upper endoscopy. This allows for direct visualization of the ulcer, determining its depth and location. And crucially, the endoscopist can take a biopsy and perform the rapid urese test right then and there to check for active H. pylori.
And what if we're testing for H. pylori non-invasively?
We have several reliable options.
Yeah.
Serologic testing for antibodies, which indicates exposure but not necessarily active infection. The stool antigen test, which detects active bacteria. And the urea breath test.
Right, where the patient ingests a labeled urea capsule.
And if H. pylori is present, it breaks down the urea, releasing labeled carbon dioxide, which we can detect in their breath.
Laboratory work also plays a role beyond the initial diagnosis.
Yes. We monitor the CBC periodically, especially looking at hemoglobin and hematocrit, to track any silent blood loss or to guide the need for blood transfusions if there's active bleeding. And we routinely test stools for occult blood until we get consistently negative results.
Okay, let's talk treatment. The goal seems simple. Eradicate H. pylori and manage gastric acidity.
Right. And eradication therapy is almost always a combination approach, running for about 10 to 14 days. We rely on triple therapy, which is a proton pump inhibitor combined with 2 antibiotics, typically metronidazole or amoxicillin, plus clarithromycin.
Or if the triple therapy fails or the patient is high risk, we move to quadruple therapy.
Exactly. Quadruple therapy ups the intensity.
Okay.
A PPI, 2 antibiotics, often metronidazole and tetracycline, plus bismuth salts. The crucial nursing teaching point here is adherence.
Right. Patients often feel better within days.
But they must complete the entire 10 or 14-day course to ensure the bacteria is completely eliminated and resistance doesn't develop.
And regardless of the H. pylori status, the ulcer healing itself requires acid suppression.
Yes, for ulcer healing, we use H2 receptor antagonists like famotidine or the highly effective PPIs like omeprazole or lansoprazole, usually for about 4 to 8 weeks. For patients with a high risk of recurrence or those with very complicated ulcers, maintenance doses might be needed for up to a year.
And what about prevention, specifically for NSAID users?
Prophylactically, we prescribe PPIs or a specific medication called misoprostol. And this is where we need a major quality and safety alert.
Okay.
Misoprostol is pregnancy category X. It should never be prescribed to or taken by a pregnant woman because it can induce contractions, leading to miscarriage or premature labor. This is a non-negotiable safety point in patient education.
Wow, got it. And for those rare ZES patients, high doses of PPIs are the mainstay.
Yes, often much higher than standard PUD doses. We might also use octreotide, which is a synthetic somatostatin analog, and it helps suppress that pathological release of gastrin from the tumors.
We've stressed lifestyle modifications, but let's just reinforce the crucial ones that actively interfere with healing.
Smoking cessation is paramount. Nicotine actively inhibits the pancreas from secreting bicarbonate into the duodenum, which is critical for neutralizing acid.
So you're fighting a losing battle if you're smoking.
You really are. And eliminating alcohol, avoiding temperature extremes in food and drink, and reducing caffeine intake are all essential, as these all increase acid secretion.
So when do we have to escalate to surgery?
When medical management fails, when the ulcer is intractable, meaning it fails to heal after 12 to 16 weeks of rigorous treatment, or when acute, life-threatening complications like intractable hemorrhage, perforation, or severe obstruction occur.
The range of surgical procedures available is pretty complex, often aiming to either reduce acid secretion or remove the damaged tissue entirely.
Right. To reduce acid, surgeons can perform a vagotomy, which severs the vagus nerve. Since the vagus nerve stimulates acid secretion, cutting it makes the parietal cells less responsive to other stimulators like gastrin.
And there are different types: a truncal vagotomy, a selective vagotomy.
And the most refined one is the proximal or parietal cell vagotomy. This only denervates the acid-secreting parietal cells in the body of the stomach, but it preserves the vagal innervation to the antrum and pylorus.
Which is a major clinical advantage because, unlike the other vagotomy types, the proximal vagotomy is not associated with the risk of dumping syndrome.
Exactly. Now, a procedure that's often paired with vagotomy is pyloroplasty.
And that simply enlarges the opening of the pyloric orifice.
Right. It's often necessary because the vagus nerve also controls gastric emptying. So when the nerve is cut, gastric motility slows, and a wider opening is needed to prevent stasis.
And finally, the antrectomy procedures.
An antrectomy is the surgical removal of the lower portion of the stomach, the antrum, which is the major source of gastrin secretion. The subsequent reconstruction defines the type. If the remaining stomach segment is connected directly to the duodenum, it's a Billroth I.
And if the remaining segment is connected to the jejunum bypassing the duodenum, it's a Billroth II.
Right. The Billroth II is a wider resection, often offering a lower chance of cancer recurrence in certain settings, but the clinical implication for the patient is a significantly higher lifelong risk of anemia, weight loss, and critically, dumping syndrome and malabsorption.
Because you're bypassing that primary absorption site in the duodenum.
Precisely. Surgeons often favor the minimally invasive laparoscopic approach for these procedures now, which leads to reduced recovery time and pain compared to open surgery.
This transition leads us directly to the most critical area of nursing care, managing the three major potential complications of PU and gastric surgery. We have to start with hemorrhage.
Hemorrhage is an immediate threat to life. The source is usually a large ulcer that is eroded into a vessel. The bleeding can be massive, up to 2 or 3 liters, often manifested as rapid hematemesis, or it can be chronic, leading to severe melena.
What are the immediate signs of hemorrhagic shock we must look for?
We have to be hypervigilant for the subtle signs. Faintness, dizziness, and nausea are the initial complaints. On objective assessment, we're monitoring vital signs every 15 minutes, looking for tachycardia, hypotension, and tachypnea.
And tracking labs and output.
Yes, track the H&H, and urinary output is a vital, fast indicator of perfusion. Output less than 1 ml/h/hour signals severe compromise.
So what are the immediate nursing interventions?
First priority is treatment of hemorrhagic shock. That means hemodynamic monitoring, securing large-bore IV access, aggressive IV fluid resuscitation, and blood component therapy. An NG tube is inserted to aspirate and remove blood clots and stomach acid, decompressing the stomach and letting us monitor the rate of active bleeding.
But stopping the source requires procedural intervention.
Yes. Endoscopy is mandatory within 12 hours. The endoscopist can perform local treatments, injecting epinephrine, applying electrocautery, or placing metal clips directly on the vessel.
And if endoscopy fails?
Interventional radiology performs transcatheter arterial embolization, TAE. They advance a catheter to the bleeding vessel and deliver an embolic agent-like small metallic coils to selectively block the flow and stop the bleeding.
The second major complication is perforation and penetration. Perforation is an abdominal catastrophe.
It is. It's the complete erosion through the gastric serosa into the peritoneal cavity. It dumps caustic gastric contents into the sterile abdomen, immediately causing chemical peritonitis, which is then rapidly followed by bacterial peritonitis. It requires immediate surgery.
And penetration.
Penetration is when the ulcer erodes into an adjacent structure, usually the pancreas or the biliary tract. The distinguishing symptom here is intense, severe back or epigastric pain that is not relieved by the standard medications that used to work for the patient.
And that also requires surgical intervention.
It does. When a perforation is suspected, we have to look for those unmistakable signs. Sudden excruciating pain, signs of impending shock, and that critically tender, rigid, board-like abdomen. Our care is focused on immediate prep for surgery, draining the stomach via NG tube, and administering broad-spectrum antibiotics and analgesics.
And finally, gastric outlet obstruction, GO. PD is the leading benign cause of this.
It is. Repeated inflammation and subsequent scarring or edema distal to the pyloric sphincter cause stenosis and narrowing, which leads to the obstruction. Patients present with persistent nausea and vomiting, feeling full quickly, constipation, and weight loss.
How is this initially managed?
We immediately insert an NG tube to decompress the stomach and relieve the pressure and vomiting. A residual volume of over 400 milliliter after initial suctioning strongly suggests an obstruction. We correct the inevitable fluid and electrolyte imbalances.
And if that doesn't work?
If medical management, including endoscopic balloon dilation, fails, then surgical intervention, often a vagotomy and antrectomy, is necessary to bypass that stenotic area.
The PDU nursing interventions really emphasize education for self-management. What are the non-negotiable points the patient must internalize for home care?
They have to understand the importance of strict medication adherence, finish all the antibiotics, take the acid suppressors for the prescribed duration, and they need to identify and eliminate irritants. No NSAIDs, no alcohol, no nicotine, and no extremes of food temperature.
And finally, understanding the warning signs of recurrence or an acute complication.
Absolutely. They must know that signs of hemorrhage include cool, clammy skin, confusion, or blood in the stool. Signs of perforation are that sudden, severe, rigid abdominal pain. And signs of obstruction are persistent nausea, vomiting, and a distended abdomen. They have to report any of these immediately.
Shifting now to malignancy, gastric cancer. Unfortunately, the prognosis here is generally quite poor. Why is that?
Well, the poor prognosis is directly tied to the diagnosis timeline. Most patients are asymptomatic in the early stages, and the symptoms often mimic benign PUD or gastritis. So by the time symptoms are pronounced enough for a diagnosis to be made, the cancer has frequently metastasized.
Typically to local lymph nodes or distant organs like the liver.
Exactly.
Who is at the highest risk demographically?
It's more common in men, older adults with a mean age of 68, and statistically higher among Hispanic Americans, African Americans, and Asian Pacific Islanders.
And diet plays a huge role in the etiology of gastric cancer globally.
A huge role. High intake of preserved foods is a major risk. Smoked foods, heavily salted foods, or pickled foods. Conversely, a low intake of fresh fruits and vegetables is associated with higher risk. And we revisit the villain. H. pylori infection is considered a major causative factor.
Other predisposing factors include chronic conditions that damage the mucosa.
That's right. Chronic gastritis, pernicious anemia, due to that atrophy and achlorhydria, and a history of a previous partial gastrectomy if it was performed more than 20 years ago, all increase the risk. And there are genetic associations, including blood type A.
Pathophysiologically, what kind of cancer are we dealing with here?
The overwhelming majority, 90 to 95%, are adenocarcinomas, originating from the mucus-producing glandular cells. And because the stomach wall is so highly vascular and rich in lymphatics, the tumor penetrates the deep layers rapidly.
Leading to early metastasis, most commonly to the liver, lungs, and peritoneum.
Correct.
The lack of early symptoms is challenging, but what are the signs of advanced disease?
They're vague until the late stage. Persistent dyspepsia, rapid weight loss, early satiety, and abdominal pain that's usually located above the umbilicus. Fatigue from chronic blood loss and the cancer itself is a very common complaint.
Are there specific late-stage physical exam findings that indicate malignancy?
Yes. While early tumors are impossible to feel, advanced disease may present as a firm, palpable abdominal mass, signs of ascites, or hepatomegaly if liver metastasis has occurred. And the most specific, and often grim finding, is Sister Mary Joseph's nodules.
These are palpable nodules found in the tissue around the umbilicus, a definitive sign of advanced GI malignancy.
Yes, unfortunately. Diagnostic assessment again starts with visualization.
So an EGD.
The esophagogastroduodenoscopy, EGD, is the diagnostic study of choice because it allows for biopsy and cytologic washings. After diagnosis, staging is crucial. Endoscopic ultrasound determines the depth of tumor penetration and lymph node involvement, and CT scans check for distant metastasis.
How do we use labs to track the cancer?
We use specific tumor markers. CEA, CA19-9, and CA50 are monitored. These markers are typically elevated at diagnosis, and critically, we track them post-treatment. A decrease in these values suggests the tumor is responding effectively to the therapy.
Treatment is aggressive and multimodal. The goal of surgery, if possible, is curative resection.
If the cancer is localized, surgery offers the best hope for a cure. This involves removing the tumor and a wide margin of surrounding lymph nodes. For tumors high up or involving the body of the stomach, a total gastrectomy is often required.
And that's removal of the entire stomach, the duodenum, and the lower esophagus, followed by reconstruction.
Yes, using esophagoesogeostomy. For tumors in the middle or distal stomach, a radical partial gastrectomy, so a Billroth I or II, is performed.
And when a cure is impossible due to metastasis, surgery becomes palliative.
Right. Procedures like bypasses or feeding tube placement are done simply to manage symptoms like obstruction, nausea, or bleeding, just to improve the patient's quality of life.
Okay, let's dedicate significant detail now to the complications following any major gastric surgery, as these really define long-term nursing management. We have to dive deeper into dumping syndrome.
This is the most common and the most devastating post-surgical complication. It's a direct result of removing the pylorus, which acts as a muscular gate. Without it, gastric contents are dumped rapidly.
What's the physiological mechanism that causes those dramatic systemic symptoms?
Well, it starts with a rapid, large bolus of hypertonic, meaning highly concentrated in sugar and electrolytes food, entering the small intestine. The small intestine reacts by trying to dilute this load, and it does that by rapidly pulling a large volume of extracellular fluid into the lumen.
And that fluid shift causes rapid intestinal dilation and increased motility.
Exactly. And that leads to the dramatic gastrointestinal and systemic symptoms.
So how do the symptoms manifest?
They're split into two phases. The early symptoms occur rapidly, about 10 to 30 minutes after eating. You see GI symptoms like early satiety, cramping, nausea, and explosive diarrhea. But the key is the accompanying vasomotor symptoms.
like headache, flushing, profound sweating.
Dizziness,
Mm.
syncope, all caused by that rapid fluid shift out of the vascular system.
Yeah.
These usually resolve spontaneously within about an hour.
And the dangerous late symptoms.
They occur 2 to 3 hours post-meal, and they're all related to blood sugar control. The rapid dumping of sugar causes a huge spike in blood glucose, leading to an oversecretion of insulin, and this results in rebound hypoglycemia.
Low blood sugar.
Right. So the patient then experiences irritability, anxiety, shakiness, palpitations, and intense hunger.
Another significant post-surgical issue is bile reflux.
Yeah, since the pylorus is removed or manipulated, duodenal contents, primarily bile acid, are allowed to reflux back up into the stomach remnant or the esophagus. This causes intense irritation, resulting in chemical gastritis or esophagitis.
And the critical symptom here is a burning epigastric pain that, unlike ulcer pain, is not relieved by vomiting.
That's the key differentiator. Treatment involves using PPIs to minimize acid irritation, and sometimes a drug called ursodiol, which is used to modify the composition of the bile itself, making it less irritating.
And of course, post-surgical gastric outlet obstruction can occur at the anastomosis site due to swelling or scarring.
Right, and the management principles are the same. NG decompression, correcting fluid and electrolyte imbalance, and possible surgical revision if endoscopic dilation fails.
Now, we tie all this together into the comprehensive nursing process for the gastric cancer patient.
Assessment is paramount. Beyond the physical symptoms, the nurse needs a detailed dietary history, documenting weight loss, tolerance, early satiety. And psychosocial assessment is critical due to the grim prognosis, covering coping mechanisms, support systems, and financial resources.
What are the main nursing goals?
Reduced anxiety, maintaining optimal nutritional status, pain relief, and helping the patient and family adjust to the diagnosis and prognosis.
Regarding reducing anxiety, this is heavy material for the patient to process.
It is devastating. We have to provide a relaxed atmosphere and proactively encourage the expression of fears, including those related to body image and potential surgical mutilation. Full, honest education involving the family helps normalize the situation and ease some of that anxiety.
Promoting optimal nutrition is complex, especially after a total gastrectomy where the stomach is just gone.
Yeah, we have to emphasize small, frequent feedings, often 6 times a day, of non-irritating foods high in calories, vitamins A, C, and iron. The patient needs frequent weighing, strict monitoring of INO, and close tracking of lab results for dehydration and metabolic abnormalities.
And the primary nutrition teaching is focused on preventing dumping syndrome.
This is the absolute core teaching, 6 small feedings daily. The food has to be low in carbohydrates and sugar, because those are the hypertonic agents that trigger the fluid shift. And most importantly, fluid should be consumed between meals, not with them.
To prevent that rapid washout of contents.
Exactly. And we also have to remind total gastrectomy patients that the lack of intrinsic factor means they need lifelong B12 injections.
Pain management must also be individualized and aggressive.
Yes, often requiring a PCA pump postoperatively, combined with non-pharmacologic measures like proper positioning, therapeutic touch, and relaxation exercises.
And the psychosocial support is essential throughout the disease trajectory.
It is. We have to help patients express their grief and acknowledge their loss. The textbook highlights nursing research showing that patients experience moderate to high levels of uncertainty at diagnosis. And while their psychological needs stabilize, their physical needs, pain, tiredness, often remain significantly high during follow-up.
So care requires flexibility.
And frequent referrals to social work, clergy, and support services, including discussions around end-of-life care planning.
Home and transitional care. The checklist from chart 40 to 5 requires practical instruction.
This checklist covers ensuring the caregiver can manage complex enteral or parenteral feedings, administer symptom relief medications for pain and nausea, and is fully versed in recognizing the signs of complications, especially bleeding or obstruction, that require immediate intervention.
Okay, to conclude our clinical overview, let's briefly cover tumors of the small intestine.
Right. These are rare, accounting for only 1% to 2% of all GI cancers, though about 2/3 of them are malignant.
And due to their rarity and the non-specific nature of the symptoms, they are generally hard to diagnose early.
That's true. The clinical manifestations are very vague, especially with benign tumors like adenomas. It might just be intermittent pain or occult bleeding. Malignant tumors, however, are usually caught at advanced stages, presenting with significant weight loss, malnutrition, chronic fatigue, nausea, vomiting, and often acute intestinal obstruction.
Assessment relies on specialized diagnostics.
Beyond the standard labs for anemia and tumor markers, Diagnostics often require an enteroclysis, which is a more sensitive upper GI X-ray series where contrast is delivered directly into the small bowel via an NG tube, providing better visualization of the lumen.
And CT scans are used to determine the extent of disease.
Of course, management really depends on the type. Benign tumors are often removed endoscopically. Malignant tumors, particularly adenocarcinoma, which is the most common type, require aggressive abdominal resection, coupled with chemotherapy and radiation. The nursing care aligns with the principles we just established for gastric cancer.
That concludes our intensive exploration of gastric and duodenal disorders. Let's provide a final distilled recap of the core takeaways.
First, gastritis. The key long-term threat is chronic H. pylori leading to mucosal atrophy, which permanently compromises intrinsic factor production and requires lifelong B12 management for pernicious anemia.
Second, PUD, prioritize the pain timing for triage gastric pain is immediate post-meal. Duodenal pain is delayed, 2 to 3 hours, and nocturnal. Management is focused on antibiotic eradication and long-term acid suppression.
Third, surgical complications are intense and require specialized nursing care. Remember the physiological mechanism of dumping syndrome. The rapid sugar load causes a fluid shift, manifesting in early vasomotor symptoms and late hypoglycemia. Management requires strict, low-carb fluids between meals teaching.
And finally, gastric cancer. The poor prognosis underscores why patient education regarding subtle symptoms and aggressive lifestyle risk reduction is vital, particularly avoiding smoked, salted, and pickled foods.
We've seen that the primary burden of these disorders stems from preventable infections like H. pylori and controllable agents like NSAIDs. So, to leave you with a final provocative thought for reflection.
Okay.
If we consider the global prevalence of H. pylori and the success of antibiotic eradication, and knowing how these infections lead to both ulcers and malignancies, how might global healthcare systems prioritize H. pylori screening and treatment in asymptomatic populations now to drastically reduce the future incidence of major surgical interventions like Billroth procedures? You should consider how preventive knowledge impacts long-term surgical volume.
A truly impactful connection between microbiology and surgical necessity. Thank you for joining us for the deep dive.
Keep synthesizing and keep learning.